All right. Thank you so much. I'm glad you're all here tonight. And hello to all the Zoomers. I hope that hi. I hope that everybody's doing well tonight. I would like to thank Jim Cox-Chapman for not only sharing your expertise and your wisdom and knowledge with us, but also your true compassion and what comes through as a genuine desire to just positively impact people. And the WISE team is so appreciative of your willingness to take the time to do this.
Oh,
So we
thank
would
you.
like to present you with a little gift just
Thank
to
you.
say thank you.
Thank you. very
All right,
much.
you're
I
welcome.
appreciate that.
And we'll get started.
Thank you for that warm welcome, and especially thank all of you who are here in church for the second time to come twice in a day to hear what I might have to say. I want to first start by introducing myself, and just to let you know where I'm coming from and how I'm approaching this subject of depression. And this is part of, you're aware, the WISE initiative, which you have undertaken, which means welcoming, inclusive, supportive, and engaged. And I think the way this is rippled out throughout the our activities as a congregation, I just find very inspiring, and hopefully it will be helpful. So I'm coming to you as a retired primary care doctor, and I think when I look back at why I went into medicine, I think I was drawn to going into psychiatry. But when I got into that whole practice, especially the severely mentally ill inpatient practice, I just didn't think that was going to be a good fit. And it also, I just felt I couldn't sit that long for during the day. So I pursued primary care, and actually probably had more occasion to talk to people who are facing mental illness or grappling with mental illness as a primary care physician than I might have as a psychiatrist, especially as the profession evolved into the psychiatrist handling the medications and the therapists doing the talking therapy. But I will say, when I look back on my practice, the most satisfying problems that I dealt with were around issues, particularly of depression. And I can tell you about one particular initiative that we facilitated in the medical group, which made a big difference to the ability of primary care doctors to recognize and adequately adequately diagnose and treat depression. And I think it made a big difference to the patients who had that experience. So a retired primary care doctor, have not practiced in 6 years. So you need to take that with as sort of the aspect. I also will say, as a person, I have never experienced some of the main things we're going to talk about, which are clinical depression, and we'll define that as we go along, and anxiety and panic. I think I came that close to one panic disorder as we were headed off for a trip, and it was to India, and I'd been there as a young person and had quite a time of it. And I kept saying to Mally, why are we choosing to go back to this place where I had a difficult time? Anyway, that was as close as I got to it. So I'm saying that I have not had personal experience, and I think things are different for people when they've had that actual experience. So my goals for this session are to educate people who chose to attend, as well as I can, about the specific conditions of clinical depression, and talk about anxiety, and talk about some of the diagnostic issues, and talk about some of the possible treatments for that. And by becoming more educated as a congregation, then that can serve to reduce some of the stigma and some of the things that we kind of imagine or posit onto mental illness. So in a short time, I'm going to ask any of you who are interested to say, why is it maybe that you came this evening? And are there any particular issues or questions or things that you came wanting to learn about that you might be disappointed if we don't cover tonight. I can't promise I can cover all of them, but and that's what the easel is for. So that's coming in a minute. So, but first I want to kind of put I want to talk about a kind of a spiritual preamble to what we're just about to talk about, because we're going to talk about the medical aspects of depression and the definitions and how you differentiate between several issues. But I think there's a spiritual aspect to depression. And as I was thinking about that, when we go through difficult times, none of us are seeking that, but when we go through a major loss or a difficult time, we often, at many times, come out the other end saying, well, I wouldn't have sought that experience, but I learned an enormous amount, and I grew, and I just became more in touch with what it is to be human. And so there's an aspect of difficult times, suffering, which can have its positive result. But I don't put, and we'll all have those trials in life because life is hard, but I don't put clinical depression, as we're going to talk about it, in that category. Clinical depression is a situation where people are stuck. So the whole notion of growth and being able to move through a condition and come out the other end doesn't really apply to chronic depression. And so in that respect, I do think it's something that if we can be as aware about it as we possibly can, and attempt to admit that that's going on, or agree with someone's impression that maybe there's something we need to look into, that's kind of what I want to get across this evening. So are there any issues that people wanted to, any reasons you want to, and you don't have to say them, but any reasons that people, why you put it tonight that you'd hope that we'd cover? We will get there. We'll talk some more. Okay. So I'll just put here situation. One person came curious about the distinction between clinical depression, and we will make a strict definition of that tonight, and situational depression, and wanted any other things that people would like to hear about, or if didn't hear about. Yes.
Strategies for helping someone in depression.
Strategies for helping someone in depression. Thank you for saying that, because I could use that every time I see my brother.
Jim, we have one of the Zoomers who's commented on elderly alone.
Okay. Yes, thank you for that. I have some things to say about it, but I haven't thought about it. Anything, George, did you have one? No? Oh.
Yeah.
Also.
This may be branching off too much, but I am interested in learning more about bipolar depression.
Bipolar, okay, bipolar. I may not be helpful on that because I haven't had a lot of experience, but.
I have another one from the Zoomers when you're ready. Why are so many young people being diagnosed with depression or anxiety?
Yeah. Just, wait a minute, I'll sit down so you can hear me. Just ask any college administrator what their budget has had to be over the past 8 to 10 years to try to deal with the incidence of anxiety and depression. I'm going to talk about that first because I didn't specifically prepare that, but Jim.
Seeing some of these interest areas, anything that we don't get to tonight, I'll try to make a point to address in 3 weeks when I give my talk.
Great, wonderful. And any way you see us straying on the path tonight, please speak up. So, yeah.
Difference between depression or just feeling down?
Yep, okay. Depression or sad. Is that okay? All right. So, thank you.
Yeah, Jim, I would have one.
Yes.
Just sort of how one would categorize seasonal depression as far as whether it's clinical versus situational or both.
That may be one that Jim will tackle in his part of this. But thank you very much. That gives us lots to work with, and I think that's great. All right, so we're going to talk. So how common is depression? And I kind of did some searching around about that and found two sort of numbers. One article thought that it affected approximately 20% of our population. The other said in any given year, 8% of the people will have been diagnosed as depression. I believe these are the diagnosis of depression, so that would be picked up in doctors' records where they're putting a diagnosis and charging and things like that. It's much higher amongst the 18 to 25-year-old age group and in women. And one of the theories about the 18 to 25-year-old age group, and this actually, I haven't read extensively on it, but the Yale Alumni magazine had an article written by one of the Harvard psychiatrists who treats that population. And there was lots of speculation about some of the parenting that's gone on for some of these kids. You all probably know the term helicopter parent, where the parents are kind of over-involved, overactive, and not just hoping that the kid won't make a mistake and as we make mistakes and get into trouble, we learn from them and we develop a sense of resistance. And Tracy Mermuska is going to talk more about resistance next week. But there's also this phenomenon, and I don't know if you've heard the term of snowplow parents, where they're going ahead and plowing the way so there will be no ripples and no difficulties for the kids. And this article and this psychiatrist in particular, thought that was a situation where someone gets to college and their parents are no longer there, although sometimes the parents try to get really involved in college, but they're no longer there, and the kids, they're running into trouble, as is customary in college, and they don't have the capacity to to kind of handle that or live with a mistake they might have made or something like that. So that is increasing the amount of anxiety in particular amongst college age. And that's I'm sure there's some other theories, but those are the ones that I'm most familiar with. And there are basically in the Diagnostic and Statistic Manual, which is the Mental Health Manual of Specific Diagnoses, there are 5 types of depression listed. One is major depression, or major depressive disorder. That's also commonly called clinical depression, and we're going to talk about that a fair amount. There's another one called persistent depressive disorder, or called dysthymia, which is more chronic and more difficult to treat, and different than the major depressive disorder. There's a premenstrual dysphoric disorder, a depressive disorder due to a medical condition, and a new one, which is new in the past at least decade, called prolonged grief disorder. So I'll start with that last one for a minute and we'll talk about it. That makes the point that grief is not depression. It makes the point that there is a small subsegment of grief, maybe applies to 4 to 7% of the people who are grieving a loss of a spouse or of a home or even a pet and things like that. And grief is something that happens to people. There are certain things that happen, and one of the hallmarks of grief is that you think things are going along okay, and then all of a sudden you can get kind of blindsided by the symptoms again. But it is a process that has a beginning at the loss and does have an ending, which is the reintegration into life, possibly the finding of another partner, or just the sense of being able to say, okay, I can now handle my life all right and move on. Whereas the prolonged grief disorder, usually you begin sort of thinking about that if things have been going on 12 months or more from the adult death of a spouse. And if someone's just stuck, they're absolutely they're having trouble believing the loss and accepting it. They're perseverating about the deceased person in a way that they just can't kind of move beyond it. Perseverating means thinking about over and over and over again, talking about over and over and over again. Not that it's not good to talk about your loss, but it's a sense of being stuck. These people also may have some numbness or kind of emotional kind of shutdown, and they may have trouble forming a new identity separate from because they had they were always associated with being with the spouse. Again, this is a small percentage of people who are undergoing the grief process. At most, the highest I could find was like 10%. But it is interesting that the psychiatry, the manual did kind of put that in as a type of depression that might need some extra attention, after decades really of saying no, grief is not an illness. Grief is something that people go through. So let's talk a little bit about I guess there's some depressive disorders due to a medical condition. I think Parkinson's is one that's notorious for having that be part of the picture. Let's talk about major depression. So we've kind of talked before, it's not really sadness. only just feeling sad. That's not a major depression. It's not grief. 93% of the time, it's not grief. And it's not just, well, I've been having the blues because I'm, and well, I mean, look at what we're all dealing with this political situation and having a president who doesn't respect the office. And I mean, that can weigh down on people, but I wouldn't say that that's major depression and wouldn't kind of fall in the category. There are a lot of ways, and Jim will go into it in much more detail about dealing with sadness or dealing with the blues. Some of that can be seasonal. There is a condition called seasonal affective disorder, which is believed to have to do with the decreased amount of light that we encounter in this time, especially in these locations in this time of year. And there are devices to and kind of programs to just be more in the presence of light. And there are some of these very interesting, more high intensity lights that you can buy and that can help people through this. But major depression is characterized often, and what's confusing is some of the same things that I just said, the blues and sadness, those are also can be part of major depression. It's a sadness and a tearfulness and a sense of hopelessness and worthlessness are probably the biggest factors. And a loss of interest, this one's important, a loss of interest in things that usually give you pleasure. So the medical term for that is anhedonia. Everybody knows what hedonistic means, and this is like the opposite of that. And this would be, I just used to love, Wednesday office hours. I'd make sure I got there every time. And now and what's the point? I go, but it doesn't really do anything for me anymore. It's those kinds of things. And that's one of the key areas in a consistent way to know that that's what you might be dealing with. There also can be anxiety and irritability. And I'm going to talk about anxiety a little bit later. Anxiety can be the presenting symptom of depression. That's kind of tricky because when someone's all of a sudden they've just developed, they're just being anxious about everything. And we'll define anxiety as we go along. That can be a kind of, oh, maybe we're dealing with depression here, and they should be evaluated for that. Sleep disturbances in major clinical depression are paramount, either sleeping too much or sleeping too little. Eating issues, eating too much, overeating, or losing all interest in food. So a lot of these are, you say eating, you say sleeping, it's got to be, it's extremes. It's one versus the other. Just an enormous amount of fatigue, trouble concentrating. Used to be able to, read something, remember it. This can, at work performance, you can have trouble concentrating. Unexplained physical ailments of abdominal pain is a culprit. Onset of headache, back pain, those kinds of things. And you've all seen or heard of people who develop these ailments and go seek good medical doctors to try to find out what's going on, and don't come up with anything. As a medical doctor, you have to be very careful of just saying, well, that's all in your head. Of course, that's a dismissive kind of thing to say, and it's not a good thing to say. But you need to take the symptoms seriously, do what is appropriate to chase down what they might be. And then if you're really coming up with nothing, then maybe just ask, well, what's life been like for you lately? What have you gone through? And you may get some of the triggers that people have. And thoughts or death of suicide. And that those thoughts, and we're going to talk about suicide in a little while also. And those are thoughts of, I'd be better off. It'd be better off if I were dead. People don't need me anymore. It just be, and it's not necessarily active thoughts of suicide about how you would do it, but just these thoughts about, well, the world doesn't appreciate me anymore. I don't appreciate being here, and I'd just be better off dead. So the diagnosis of clinical depression, it's something that there are a couple of ways. Let me just make sure. Yeah. So a primary care doctor, a primary care APRN, a psychologist, an MSW, medically trained, a social worker, or an MD, either a primary care doctor or psychiatrist. These are all people that should be able to make the diagnosis of major depression. Some of them can, and all of them can treat with, well, maybe with the exception of the primary care doctor so much, but with therapy. And some of them can prescribe medications, but all of those people, and I don't think I've missed any, but I think it would be a psychologist and a trained social worker, an MSW, an APRN, or a PA, and then the various medical professions. They should be able to make that diagnosis of, Heather, I haven't missed any, have I? A counselor, yeah, right. Yeah, that I think I was doing that by the social worker, but yeah. When I started practice, you just kind of had to feel your way through this and talk and ask questions, and get an idea that was going on. And when I started medical practice, and this would have been more than about 35 years ago, primary care doctors weren't all that well versed in how to treat depression. And there was no specific way to diagnose it. It was kind of, you were kind of groping in the dark and figuring out something. And you didn't really have a lot of tools at your disposal to treat it. So it wasn't being done very well, and it wasn't being recognized. And not that people weren't trying their best, and people weren't empathetic about what was going on and wanting to help, but the kind of diagnostic parameters were, at least for primary care, a little fuzzy. And then the knowledge of medications in particular, we weren't as well versed as we were in blood pressure medications and breathing and all those kinds of things. So there have been some advances, and what I'm gonna do now is, if you would hand out. Okay, I have a handout. Now, don't just think you have to read the whole handout. That's not the point here. Go to the last page. Go to this page. Okay. And what I'm handing you is that, for me, was a major advance in being able to deal with, diagnose and be more competent about treating major depression. So what I've handed you is something called the PHQ-9 test. This test, I'm not exactly sure when it was developed, but it's a clinically valid test that's easily administered, and is able to really sharpen the discussion about whether or not we might be dealing with depression here. And when I learned about this, and the way we learned about it is our medical group got a grant from the MacArthur Foundation, and they were interested in four things, really. The first, they were interested in helping primary care doctors improve their diagnosis of depression and understanding of it. The second is they were interested in helping them be more versed in what medical treatment could be available and what treatments could be available for depression. And the third was at that, they were aware that if someone was seen in the office and diagnosed with depression and given medications, that 50% of the time, within a month, the person stopped taking the medication. So they wanted to see if we could do something about that. And I guess the fourth thing they were interested in is they wanted to help people and help people get better treatment and because the treatment is effective. So we're going to talk about that in a minute. But so if you look at this, the first two questions on the top of this this last page here, this PHQ-9, are any of you who are Medicare age, you've seen these questions. Do you have little interest and pleasure in doing things? That's what I talked about before, about being the major thing. Have you been feeling down, depressed, or hopeless? And then your choices are, nope, not at all. Yeah, several days. And the window of time here is over the last 2 weeks. So you're trying to, again, this is a way of trying to isolate things and measure things. And I, for one, thought depression, you can't measure that. What are we talking? But this is actually quite helpful. And it's helpful to the patient. It was helpful to me as a doctor, and it was helpful to the patients too, because they could see that they were, if they were improving. So little interest and pleasure in doing things. Yeah, over the several days over the past 2 weeks, I could say, yeah, I just haven't been up for training the way I used to, or something that used to give me pleasure. Yeah, more than half the days, I'm just like not interested. And every day I'm struggling with not being interested in those. So those first two questions, and again, if you're Medicare age, you've seen these because these are screening questions. If your answer to those is nope, not at all for both of them, then you don't need to go on and take the whole rest of the test. So it does help screening large populations, and you've seen that in the physical exam when you go for the yearly visit when you go for your primary care doctor. So and it's useful because if the answer is 0 on the first two questions, then it's not going to be, you're not going to have stuff on the last. So these are, again, the symptoms I talked about: trouble falling or staying asleep or sleeping too much. You can read them, what they are, questions 3 through 9. And let's see, I talked about feeling bad about yourself or you're a failure, trouble concentrating. We talked about that. The moving or speaking so slowly that other people could have noticed. This gets more at the very depressive, slow symptoms or some of the manic bipolar symptoms where you're just kind of agitated and speaking in a kind of pressured way. That's what that's trying to, and fidgety and restless. And then the one about the thoughts that you might be better off dead or hurting yourself. That's an important thing for any therapist or any person who's treating you to pick up on and to inquire. And what I want to stress is that this is something that if it comes up and it occurs to you and you're talking with another person or trying to help out someone who's depressed, it's really it's a good idea to talk about it. You are not going to give the person the idea about committing suicide by bringing it up. And it's something that I think is important to have a frank honest conversation about and gauge in your own way how likely it is that that person would do something. And there are lots of answers. Yes, I've thought about that. I'd be better off dead, but there's just no way that I would have the courage to do anything about that, or I wouldn't know how to go about it. Or yes, I've thought about that. And I've got, guns at home, and I've got the lock to the, then that's a whole nother conversation. But that, and so I guess what I'm encouraging you, even as concerned friends or relatives of people, is if that comes up, try to explore it. You're not going to give someone the idea by bringing it up. So that's one of the things I wanted to say about suicide and important aspect. So the way this worked for us in practice was I would spend some time talking to the patient, kind of find out what was going on. If I had an idea that this was going on, then that was a situation of saying, well, maybe you're depressed. Have you thought about that? Usually the answer is yes, no, I'm not depressed. And they're trying to, back off from it. But you get them to agree, this is in the medical setting, or even you could ask some of these questions. And if they're scoring a lot of them, especially on the nearly every day, that is a way of saying, when thousands of people are given this test and they're getting a score the way you are, that's usually indicates that they have a clinical depression and they will benefit from therapy. And the other thing you can use it for is when they come back, let's say in a month, because most of the medications we use to treat, if you're using medication, most of the medications we use to treat take 3 weeks to get any kind of effect. So if they come back in a month, and I'll get to the dropping the medications in a minute, or maybe in 2 or 3 months, then you can administer the test again, and there might be an improvement, and that's encouraging for people. At least I found that in practice. The issue about dropping medications, 50% of people drop medications within the first month. One of the aspects of depression I talked about was physical symptoms that sometimes can't be explained. And a day or two after they'll start a medication, you get a complaint about they notice something different, and boom, stop the medication. And one of the things you need, and again, as a friend, to say to people is, your doctor thought there was good reason that this would help you. If you're stopping, you need to tell the doctor, you need to call them. And what this study did that we did was that it paid for someone to call each person who'd been diagnosed with depression 2 weeks after they were seen, and check in with them and see how they're doing. And that dropped, that improved the medical adherence rate. So it improved the people staying on their medications from had been 50% to 85%. And it was just a wonderful, satisfying thing to be able to do, to add this element. Now, unfortunately, the way healthcare is financed, this person was calling people from all different, who had all different insurance coverage. We were paying, or the study was paying for it. And when the study stopped, there was nobody there to pick up that task. But it was a very gratifying thing to realize that we were increasing the amount of people staying on the medication. So I've talked a little bit about treatment. Jim's going to talk more extensively about self-care and the ways that you can do. And there's a lot we can do as a church congregation to care for people and encourage them to get the self-care that they need. Therapy, talking therapy, or counseling either in person or online, either one were thought, according to the research I found, were equally effective. And there was a marginal improvement if you combined pharmacological or medication therapy with talking therapy. But really, talking therapy or medication therapy are equally effective. And I think in some situations it helps to have both, and it also helps to have insight into what was going on and why you had ended up this way, and the fact that you would get better. So I'm a great proponent and believer in talking therapy, but there were a lot of people that I saw in primary care practice who would have none of this, but they would take medication, and they did notice that they were better. And that was a very gratifying thing. There's also cognitive behavioral therapy, which is a specific type of therapy. And that also is equally effective as the in-person counseling or the online and medications. Cognitive behavioral therapy is, you can find that there's certain pockets of places that will do that and do it very well. But it's not generally, if you go to a counselor, that's not generally, Jimmy, correct me if I'm wrong, but that's not generally, if it's a specific type of counselor who does that kind of thing, yes, but the talking therapy people aren't necessarily going to be doing that all the time. Yeah, good. So the pharmacological therapy, when I started out practicing, the main drugs we used were these drugs called tricyclics, which were an older type. They were really good to help people sleep at night, which was nice. You take them at night. Their big drawback was a dry mouth, and also that if somebody decided that they wanted to commit suicide, they took a whole jar of it. That was an unfortunate aspect of the medication. So and there was an effort to try to get away from those medications because of that risk for people. The most common brand of Medicare or type of medications are what called SSRIs, or serotonin reuptake inhibitors, and that I think Prozac was the first one. Lexapro is another one now. Zoloft is another one. There are a whole slew of them in that it basically operate more or less the same way. But again, the difficult issue is, in order to see any effect, you really need to be on them 3 weeks minimum. So if one and there have been some genetic, I think, advances so that you can test some genetic things to see who will respond to Zoloft in particular, as opposed to Lexapro or as opposed to Prozac. So there've been some advances that way. I'm not sure how widely those are used, but that is some new, but there was a lot of, or is, maybe not still is, but was a lot of trial and error about finding the right medication, the right dose. And so that is something, and when it's a 3-week lag time, that proves that some of the difficulty. The other medication, Wellbutrin, has a different formulation that acts more quickly, and is one that often is combined with the SSRIs. The other not ever talked about, but something you just need if you're just want to be knowledgeable about this. If you talk to really any psychiatrist, and they will tell you that electroconvulsive therapy, or ECT, is the most effective way to treat depression. I had a personal example when one of my close college friends was profoundly depressed, and to see what happened to her with 1 or 2 treatments of ECT was just extraordinary. But again, that's anecdotal. And there's a whole stigma around ECT because of One Flew Over Cuckoo's Nest, and the suffering and indeed in early times, and this is before I was even practicing, the convulsions that people would have and the broken bones and things like that were a real drawback. But that it is now a much more controlled, safe procedure, and hard one for people to kind of contemplate that they might do that. And it does have a drawback of amnesia after, you can have a drawback of amnesia afterwards. So let's see. So I think that's probably what I have to say. I want to talk a little bit about, I talked about the young. I'm probably not going to talk about the bipolar much. Elderly alone, loneliness, and being alone, which is not the same as being alone actually, but experiencing loneliness is a powerful negative, has a powerful negative effect on health. Nowadays, people are saying that it's equal to smoking a pack or two of cigarettes a day in terms of the harmful attitude ways that it can affect people. And I think that offers an opportunity for us as a church family to be reaching out to people and letting them and visiting people and letting them know that that they're important. They're important in general and important to the church. But being alone, and it's also in my practice of medication and now medicine, and now as I'm entering into the age, the whole notion of your house and whether or not when you're alone you stay in the house, and what that does in terms of isolation and things like that, especially if you can't get out and about, is something that really needs to be taken seriously. And there are different ways to handle this, and just because you're living alone in a house doesn't mean that you're necessarily lonely if you're interacting with family. But I think the definition of isolation or loneliness is when you take a questionnaire and you say, and then one of the questions is there anybody that you can call or talk to about what you're going through? Is there anybody that you have to call if something was happening or you had a symptom you wanted to talk about? Is there anybody that you're talking with on a regular basis? And that can be family or friends or whatever. But if the answer to all of that is no, that is a cause for concern. Strategies of helping. Yeah, that's tough. That's very tough. And I guess the only thing I can say is that what I'm learning of the difference between the life I had as a doctor and the life I envision as more pastoral in this setting is that we can't fix everybody that in the way that we think they ought to be fixed. And the doctor orientation is totally toward fixing. And let's, as this talk I've given has kind of demonstrated, and some of the problems that people have, especially if someone who's been chronically depressed, they're older and they've been that way so long they can't see any kind of other way, then I think you need to be a caring person, but there's a fantasy that if I could just say the right thing, or I could just have the right person talk to them, that then they would see and they would, and things would turn around. And I think that's more a sense of I think the answer is just by being there and being available for them and telling them you care about them. We have to meet people where they are, unfortunately, and it's painful. It's really painful because where they are is not where we know they could be. And but I think that's part of the aspect of helping, but also sending the message that I think you have the criteria of, depression, and there is treatment and it does work. That's something that, that people need to hear. And why we've developed this stigma about mental health such that, someone walking around being unable to walk because they've sprained their ankle badly or they've broken a bone, they'll accept treatment. But people have the same kind of disability with depression, and there's a stigma about not. And I think that's a shame. That's pretty much all I have to say. So thank you for listening. Oh, yes. Thank you. Thank you.
Could I just respond before I answer that? So what we know is that not all of us know how to ask for help or to know what help we actually need. So there's an algorithm that has become very popular, especially with kids and adolescents, and it's the 3 H's. So you can ask somebody, you need to be heard, hugged, or helped.
Oh, yes, I like this. Yeah.
And that sometimes that can be a prompt to help somebody kind of actually begin to identify how they can be helped, because especially in depression, we can lose the ability actually to know what we're feeling and what kind of help we need.
Oh, that's very helpful. Yes, I thank you for bringing that up, because by asking, do you want to be heard? Do you want to be hugged? Do you want to be helped? You're giving that person agency to determine what it is they want from you instead of forcing it on them. And I think that's a great, and heard is, there's a lot, so that for some people, there's a huge amount of value in venting, and it's not necessarily, oh, well, now we got to go. No, they just want to unload this, and that's helpful. So let me just finish up about anxiety, and then we'll wrap. So anxiety, I'm gonna read you the definition, and this is according to the American Cancer Psychological Society. It's an emotion characterized by feelings of tension, worried thoughts, and physical changes like increased blood pressure, increased heart rate, which you can tell. It's future oriented. And it's a long-acting response to a diffuse threat. So fear, and they're sometimes used interchangeably, but not from a definition point of view. Fear, on the other hand, is very present. You see that car coming toward you and you are frightened, and it's oriented to a very specific threat, not a diffuse kind of threat. And anxiety can sometimes trigger a panic attack. And a panic attack is defined as a sudden episode of fear or anxiety that triggers such a significant debilitating physical reaction, and there's no real danger present, but it's such a debilitating reaction that you need treatment, or you can't function, or you're having extraordinary pain or something like that. And that's a physical reaction triggered by anxiety. So anxiety is a diffuse kind of threat. And I actually personally think, and I think some anxiety is really good and really helppful and part of our life. I certainly felt that way, studying for tests and getting ready to do something or what, but chronic anxiety, having that chronic diffuse kind of fear of amorphous things can be very debilitating. And the treatment for those, again, Jim will talk about some of the self-care treatment. There are medications available, none of which people love to take. They take them kind of, and when they're handling this well, they're aware enough that they're anxious, and then they say, gee, maybe I better do something to diffuse this situation. I better leave, or I better take that medication. There's one medication available that you take chronically that tends to lower the amount of anxiety, but most of the medications are an as needed basis. And some people like them, some of them don't. They do have some addicting effects to them, but they can be effective. And oftentimes, if anxiety is a big part of your depression picture, that you can be, when you're started on antidepressant medications for the first month or two, you might have an anti-anxiety medication, because if that's your major symptom that, gradually gets kind of contained, then, it's good to have something available to do that. But a lot of, and that's where, again, therapy is helpful to realize when you are anxious. And I've certainly had times where I've gotten this kind of bolt of fear, and then I've realized, wait a minute, no, that's not a real situation. That's just anxiety, and it's going to be okay, and it's all right. So I hope that's helpful. But again, it can be the major presenting symptom of depression. We have time. It's 6:30. We have time for a couple of questions.
Thought
Yeah.
to share, as we're talking about it. I'm remembering, several of us attended a training here, called QPR training. And when you talked about the 3 H's, I thought acronyms are great because we can remember them. And I thought the QPR training was about suicide prevention. But the concepts, I think, can apply to a lot of what you're saying about how to be helpful to the people in our lives. It's question, persuade, and refer. And I think when we're dealing with somebody who we're concerned about them possibly either being suicidal or just being depressed and needing treatment, if we question them, and if we find that we really think that they need support, we persuade them to be open to that support, and then refer by encouraging them to seek the help that they need. I think it's sort of, it works for general depression as well as suicide prevention. So I just another acronym to kind of put in the back of your mind.
Yep. Do you have?
Oh.
Wait a minute.
Physical illness and how connected.
My answer to that is yes. And I wouldn't say that, other than that I have a lot to say about that. Certainly the training that I received was inadequate to really appreciate that. But I do think there is a huge connection. And I don't know if Tracy or Jim will be talking about that later on, but anyway. So
I just had 2 points. I recently was with my mother-in-law doing one of these questionnaires, and she's approaching 80, and anxiety. Oh, no. And I'm like, but you worry. And she's like, oh yeah, I worry all the time. I pray a lot at night and I worry. And you have a lot of negative thoughts, like you're always saying, oh, well, that's not going to work, or that one. And she had no idea how to define these words. So what I would say is, as a caregiver of older people, to go with them and try to get down to the simplistic words of, you talk a lot and you always say negative things. Oh yeah, that's not going to get better, or whatever. And that's her definition of depression. But she would say, no, I'm not depressed, and no, I don't have anxiety, but she worries all the time. So I just wanted to share that as a caregiver of older people, that's what I found. As a pharmacist, I wanted to say,
as a pharmacist, you said?
Yeah, the 3 to 6 weeks for medication to work, but there's also the flip side of 3 to 6 weeks for the side effects of a medication to wear off.
Right.
Your body's going to get to it. So, talk therapy is a great way for that therapist to say how you're doing on your med. If you can start the therapy with the medication at the same time, they can be that call that you no longer can afford to do, and ask them how that's going, and to pre-educate them that the side effects, a lot of upset stomach, headaches are very popular with the medications.
Right.
And those will wear off once your body gets used to it. Kind of like exercising. Your muscles hate you when you start exercising.
Correct.
But after 3 to 6 weeks, if you use that analogy, it will be better and your body will love it in the end. So
Yeah.
those are my 2 comments.
Oh, that's very helpful. That's extremely helpful. And that is part of, yes, the medical things. And then, but the language about meeting people where they are, about how they define things is very, very helpful.
So on behalf of the helicopter parents in the room, I will say I've worked really hard to arm my daughter with tools, so that she's more resilient than I was. But I see the rise of diagnosis among young people as a good thing. They're willing to get help. They're willing to, I'm not saying it's trendy. I'm saying, it's more,
Yeah,
Yeah,
I like that.
my daughter was more willing to get help than I was. And so hallelujah, I will take it.
Thank you. Yeah, thank you for that.
Okay.
Just to respond to the mind-body issue, the simplest way I can think of it is that I see depression and anxiety as inflammatory diseases. And what we know from all the literature is that anything that increases the release of stress hormones physiologically will then impact, in your field, the medical side of things. So the mind-body connection is a very legitimate concern. And so that's why we want to really work together as a community to reduce stigma so that people can actually talk to their physicians and advocate for themselves and to really stay on meds and stay in therapy. So.
Great. Thank you. Bill? Oh, another.
So it says, thank you. Yes, the side effects can be brutal, especially if not told.
Yes, good point. Good point. We have time for one more question.
Well, it's not a question actually, but another reason I think that people sometimes stop the medication is because they start to feel better. And that's probably longer than 3 weeks.
Right.
But, oh, I feel better. I don't need this anymore. And if it's a real clinical issue,
True.
then
Yeah,
you
yes,
need to
and
continue it until somebody decides that
No, that's a
who
good
knows what
point.
they're doing decides.
I
to
don't
keep
have
it
a
going.
lot of data on that, but that we, they start feeling better and they stop the medication when really probably you need a good 6 to 9 months on the medication. But I think the other rule of thumb, if for all of you and if you're anybody you're taking care of, if you're going to, the doctor, hopefully you have confidence in, put you on that medication for a good reason. So if you're stopping, you need to let them know. And it's not that you're a bad person or anything like that. You have a legitimate, in your mind, reason for stopping, but talk about it, which is really important. Yes, that's true too. Right. Yeah, that is true. Great. I think we got one more.
Yes, thank
thank
you.
you.
The mind-body
Oh.
connection, a therapist can help provide tools like breathing, change settings,
Yep.
etc.
Good. Well, thank you very much. Thank you for coming out. And we can look forward to Tracy next week and Jim in
3 weeks.
3 weeks. Okay.
I was
Great.
supposed to let all of you know something before and forgot. So, you were handed a piece of paper when you came in, for some suggestions of topics that you would like additional information about. If you filled this out or have anything to put on it, you can leave it at the table here, or there's another table in the back. And it says, are there any mental topics you would be interested in? It was intended to say, are there any mental health topics? So that was just a little typo, so we apologize.
Thank you, Jim.
Okay.
Thank you so much.
And thank you, Al, for the Zoom. Did a great job.